written this talk to celebrate a Cushing's Awareness Day. And we're going to talk about Cushing's disease this afternoon. This is a specific type of pituitary condition. And I know that some of you who have joined may not have had Cushing's disease, but I'm hoping that for all of us, there's a bit of education in there, and we'll talk about some general principles around the pituitary as well. And then as we've heard about, and thank you again to the organisers for asking me, we'll have questions at the end. Okay, so what are we going to talk about this afternoon? It's just good to have a bit of structure so that you know where I'm going over the next 30 minutes or so. So I'm going to just describe what Cushing's is. I'm going to describe the difference between Cushing's syndrome and Cushing's disease, because that comes up sometimes. Also, what happens to the body when there's too much cortisol? How do we diagnose Cushing's disease? And what are the treatment options for Cushing's disease? And actually, one thing just to say, and maybe Amy might put it in the chat, is that Amy very kindly worked with me, and I organised a blog as well about Cushing's, which has some of this story in it. So it might just be helpful to have a look at that if there's anything that you're interested in from what I say over the next 30 minutes or so. So Cushing's disease, what is it? So I just want to remind you about the hormone in question for Cushing's. So each of us have two kidneys, okay? One on the right, as you can see here, and one on the left. And on top of each kidney, like a little hat, is the adrenal gland. Okay, again, one on the right and one on the left. And if you were to cut through the adrenal gland, you can see that it's got this outer sort of core that we call the adrenal cortex and an inner medulla. And the medulla makes a very different type of hormone to the one that we're about to hear about. The medulla makes our fight and flight hormones and is nothing to do with Cushing's. But Cushing's is where this adrenal cortex makes too much of the hormone cortisol. And that can happen for a number of reasons, but that's what Cushing's is, too much cortisol. Okay, so next thing is, and as I say, look, I'm trying to be very general because people have all different levels of knowledge about things pituitary-wise. So let me just move this out of the way for a minute. So cortisol is what we call a steroid hormone. So it's all steroid hormones are made from a precursor of cholesterol. Steroid hormones bind to receptors inside cells, and there might be other steroid hormones that you might have heard of, like estrogen, testosterone, progesterone. They're all steroid hormones too. So there's a big family of steroid hormones. So I want you to concentrate on this diagram, first of all, on the red line. So this is just telling you about cortisol having a very special, what's called diurnal rhythm. So let's go to this box. So a diurnal rhythm is where something changes throughout the day. So on the bottom of the graph here is the time of day. And as I say, we're just going to focus on the red line to start with. And here on this vertical axis is the amount of cortisol in the body, in the bloodstream. So you can see that cortisol rises very early in the morning, and it's the hormone that gets us out of bed, honestly. You know, whilst we're whizzing around in the morning, whilst we're, you know, trying to sort ourselves out, if we've not had any issues with our pituitary or adrenal glands previously, cortisol is the hormone that's going to get us going. And then it falls over the course of the day, and then it starts climbing up again in the early hours of the morning. Now, we've just discussed that Cushing's syndrome is any cause of too much cortisol. So when you've got Cushing's, too much cortisol, you can see now looking at this blue line that the problem is you have cortisol at high levels all day long. And that causes a number of symptoms and signs, which we'll look at in a minute, but it also causes the patient to feel quite to have difficulty sleeping, I think. And sometimes I think certainly patients feel a little bit stressed with too much cortisol, because essentially the whole point of it falling later on in the day is to allow you to go to sleep. And patients with Cushing's often describe not being able to sleep very well because their cortisol is high even in the evening and night time when they're supposed to have a low cortisol and be ready to go to bed. Okay, so these are diagrams. You'll see the signature at the bottom here, Netta. And some of the terminology is quite old because these are very, very, very old pictures. But this was a really interesting man who was born in 1906 and grew up in New York in the sort of Great Depression, really, and was very, very artistic and wanted to be an artist. But his family thought that there was no money in art and that it wasn't a reputable career. And so they suggested to him that he became a doctor instead, which is what he trained to do. But he never lost his love of drawing, and as a consequence, he's a really celebrated medical illustrator because he was really key in being interested in the human body and in medicine, but also using his artistic abilities to sort of make this whole atlas, not just for endocrinology, lots of different conditions, this whole atlas of pictures to really all in one picture show all the different features of something. So as I say, some of the terminology is a bit old-fashioned, but it's just quite helpful to see everything as a whole. If you've got too much cortisol, which is Cushing's, you may have some, all, or none of these symptoms, but typically you would have at least one or two of these rather clinical features rather than symptoms. It might be a clinical sign that you have. So if we just start at the top, this is a patient with Cushing's. So this patient has got red cheeks, which is very common in Cushing's. She's got a round appearance to her face. She's got some fat increase as a pad there between her shoulder blades. We don't call that a buffalo hump anymore. We call that an interclavicular or interscapular rather fat pad. Very, very commonly you have thin, vulnerable skin with Cushing. So you can bruise very easily. You can cut yourself. You can see at the bottom here, actually, you don't heal very well if you do cut yourself. You often have red stretch marks, which are called strie, over your tummy. And then you can see, and sometimes over your sort of bottom and upper thighs. And you can see here that this lady has got quite thin arms and legs, but all her fat distribution has increased around her tummy. And we call that central adiposity or central weight gain. It's just meaning that the tummy has taken on a lot of fat, whilst actually in terms of fat tissue, whilst a lot of her arms and legs, her tissue has wasted there in terms of they're thinner. She's got less muscle, for example. And she's also going to have a vulnerability to vertebral fracture, and that's, or to fracture of any part of her body, but particularly her spinal column, which is made up of vertebrae, because she is going to be vulnerable to osteoporosis. So we know that very high levels of cortisol thin the bones, that's called osteoporosis. And the issue with osteoporosis is it increases your risk of fracture. So as I say, for those of you where this is relevant about Cushing's, you may recognise some of these features that you might have had. As I say, you don't necessarily have to have all of them, but these are the sorts of features that we would be looking for when we are assessing someone with Cushing's. Sometimes it's a lot less clear than this picture. And for example, I've talked about this wasting of the muscles in the arms and the legs, and we commonly get somebody to try and, if we're suspicious that they might have Cushing's, we ask them to stand up from squatting to see whether or not they find that difficult. The patient might, for example, describe difficulty climbing stairs, which again is this weak muscles at the top of the legs, particularly, we call that proximal myopathy. So quite a few clinical features to look for Cushing's. Okay, so we're here this evening because we're all interested in the pituitary gland, and of course the pituitary gland is critical to all of this. So I thought I'd just describe to you this chain of command that happens in all of our bodies normally without having a pituitary problem, and how that sort of relates to Cushing's. So, sorry, I've gone. So at the top of this chain of command is a hypothalamus. The hypothalamus sits in the base of our brain. That's very important for things like our weight and regulating our temperature. But our hypothalamus also tells our pituitary gland what to do. So the pituitary gland also sits at the base of the brain. And the pituitary gland does not work by itself. It has to be told what to do by the hypothalamus. The pituitary gland, in turn, as we know, it's the master gland, so it tells lots and lots of different body systems what to do. But in this case, when we're talking about Cushing's, we've just learned that the adrenal cortex makes lots of cortisol, and the pituitary gland will tell the adrenal cortex to make cortisol. And it does that by making a hormone called ACTH, and that's the abbreviation for a very long hormone name called adrenocorticotropic hormone. So we abbreviate that to ACTH. So outside of Cushing's, in normal physiology, the pituitary makes a little bit of ACTH that travels to the adrenal cortex, and it tells the adrenal cortex to make cortisol. And that's how the adrenal gland normally functions. So the next thing I want to talk about is what's the difference between Cushing's syndrome and Cushing's disease, because that sometimes comes up. So Cushing's syndrome is any cause of a high cortisol. So that could be a tumour of the adrenal gland, for example, making too much cortisol. Sometimes we see this caused by medication. So there are lots of conditions, medical conditions, where you may need very high doses of what's called steroid. And we use that word for tablets typically that are very like cortisol. And that's important because cortisol, one of the effects of cortisol is it dampens down inflammation. So we typically use these steroids, as we call them, for any sort of inflammatory condition. So people who have acute asthma and have a flare-up of that might need high doses of a steroid called prednisolone that works a bit like cortisol. Rheumatoid arthritis, for example, another inflammatory condition, patients might need a big dose of something like prednisolone again, or a similar steroid to dampen down the inflammation. And sometimes if patients take very high doses of steroids used for these kind of inflammatory conditions for a long period of time, they can also develop some features of Cushing's because the body is seeing that like very high levels of cortisol. So specifically what Cushing's disease is, and this brings it back to the pituitary, because here we are in a Pituitary Foundation conversation. So the most important thing is to remember why we're here, and it's about the pituitary. This is the person whose birthday we're celebrating, of course, because this is Harvey Cushing, and this is why we have Cushing's Disease Awareness Day every year across the world, actually. So Harvey Cushing was a neurosurgeon, an American neurosurgeon, very distinguished person in that I don't know how he found the time, honestly, when I look at all his accomplishments in terms of, you know, very famous author as well. So sort of found a lot of time to do lots of things, let's just say. But he was the first person to describe the features of Cushing's that we've just seen in that sort of a medical illustration. And he linked those to a pituitary tumour. Now, don't forget, this was a long time ago, so he didn't really know so much about how it all worked, but he definitely was the first person to put together these symptoms and signs and the fact that it was linked to a pituitary tumour. And so we use the word Cushing's, or the phrase Cushing's syndrome, for anybody who has high cortisol of any cause, okay? As we mentioned, could be an adrenal tumour, could be too much medication that works like cortisol, but Cushing's disease is very specifically a pituitary problem. So Cushing's disease is where there's a pituitary tumour making too much ACTH. So just remembering that diagram I showed you a minute ago, ACTH comes from the pituitary, tells the adrenal cortex to make cortisol. So if you've got a tumour making too much ACTH, the adrenals are going to make too much cortisol. Okay, so for some of you who've had a diagnostic workup for Cushing's, there's a sort of two-step process. So first of all, as we've been learning about, Cushing's is too much cortisol. So first of all, we have to prove that there's too much cortisol. And we can do this in a number of different ways. Now, there's no perfect test for Cushing's. And if anybody, just thinking about, you know, you might look at this list of investigations and think, well, I didn't have some of those. But every centre would have a variation on a theme, but they will be very much a theme. So you can do a 24-hour urine collection where you collect all the urine you pass for 24 hours and you measure the cortisol in it. That is quite hard work for patients, but it's definitely doable. And obviously, if you had very high cortisol levels throughout the day, your 24-hour urine collection of cortisol would be high. Now, casting our mind back to that diurnal variation where cortisol is highest in the morning and low at midnight, what we can do is measure the cortisol at midnight, and it should be low. In Cushing's, it'll be high. If the patient needs to be asleep when we do that blood test, they ideally need to be in hospital. Those of you who have had an overnight stay in hospital, not a relaxing place to be. Typically, you don't sleep very well. So sometimes that's a bit of a challenge, unless you've got a specific investigation unit for endocrine patients where it's a lot calmer and you're not sort of trying to manage everything going on a medical ward at the same time. What we're starting to use much more of, because as I've mentioned, having a blood test at midnight can be quite challenging, is we're actually using a lot of what's called late night salivary cortisols, where for those of you who have done this, you get given a tube and a sort of cotton wool plug, and you sort of swill the cotton wool plug round for a minute, couple of minutes in your mouth until you sort of make it all wet. And you're given some very specific instructions about not brushing your teeth so close to doing the collection, etc., so you can't contaminate the cotton wool plug. And then you pop that in the tube, you send that back to your centre, and they can measure it either at that centre or they'll send it away to be measured. So that's quite good because you can do multiple samples of that. You can actually do that from your home. You don't have to come in for lots of investigations. As I say, it's a good, robust test. So we're using, certainly in my centre, more and more of those. And then the other test that a lot of people are still using, myself included, is something called dexamethasone suppression. So dexamethasone is also a steroid tablet, quite a potent steroid tablet. And so in someone like me who is 100% healthy, if I took dexamethasone, it would switch off my cortisol the following morning. And when I had a blood test, I wouldn't have any cortisol measurement at all. But in Cushing's, because the problem is the cortisol is so high, the dexamethasone can't switch this off. And therefore, we would say that that person doesn't suppress on dexamethasone, and that can be an indicator of Cushing's. So once we've confirmed there's too much too much cortisol, and we feel that the patient has Cushing's, we then need to work out where the problem is, because as you saw from that diagram, it could be that you've got a pituitary tumour, could be that you've got an adrenal tumour. You do take a very, very careful drug history, so you would have worked out if the patient was taking too much steroids in terms of medication causing the problem. But also very, very rarely, you can have a tumour somewhere else in the body, often a lung tumour, which is not a typical lung cancer as we know it. It would be a very, very special type of tumour called a neuroendocrine tumour, where it actually releases hormones that aren't typically made in the lung, for example. And so you can have a lung tumour making too much ACTH. So if we, once we confirm that we have got a diagnosis of Cushing's, so we've shown that the patient's got too much cortisol, they're making too much cortisol, we've excluded a medication problem as a cause, we then often will do a pituitary MRI to look for a pituitary tumour. And some centres I've put here, just in case this is familiar to you, might do something quite fancy called an inferior petrosal sinus sampling, where you have blood taken from around the pituitary through a series of catheters that are pushed up through a big vein in your groin to sample ACTH from the pituitary and make sure it's coming from there and not from a lung cancer, for example, but that depends very much on the centre that you're at. Now, I wanted to bring this up because this is one of my favourite quotes, actually. I have used this quote before in a talk to doctors at the British Endocrine Society, not to patients, but I thought actually when I was making this talk that it was really important to revisit this quote. So this is a picture. I've never met this gentleman, but he is a famous physician, endocrinologist in the States, and an expert on lots of endocrinology, including Cushing's. And I do, you know, he's got a very proliferative publication record, and I really enjoy reading his papers. But I found this at the end of this paper once, and I thought, gosh, this was so true for Cushing's. So he wrote, clinicians who've never missed the diagnosis of Cushing's syndrome or have never been fooled by attempting to establish its cause should refer their patients with suspected Cushing's to someone who has. In other words, what he's saying is it's actually a tricky diagnosis. And if you sort of think this is all easy and straightforward, you just need to do the test, bang, 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 this is the problem, you actually should be sending your patient somewhere else, because in fact, Cushing's disease and Cushing's syndrome is quite complex to diagnose. So why is it difficult? Because obviously as a patient, you might think, well, that's why is it difficult? You know, I don't want to have a difficult diagnosis. I think the issue really is that I showed you that illustration from Netta with a whole constellation of lots of different clinical features. But in real life, patients very often don't have lots of those clinical features. I think the difficulty is some of the features that are typical for Cushing's, which would be this weight gain, they could get high blood pressure, they can get type 2 diabetes. Unfortunately, that's also an increase in incidence in the general population. So, you know, gaining weight or developing high blood pressure or developing type 2 diabetes doesn't necessarily mean that you've got Cushing's. And I think when there's an increasing sort of frequency of these conditions around anyway, then makes it difficult to sift out what is caused by something more than just you know, current life, and whether or not it's actually a hormone problem like Cushing's. I think the second thing to say is that none of our tests are perfect. I suppose I think that in endocrinology, some tests are probably less ambiguous than others. But I think Cushing's is also challenging because none of our diagnostic tests are perfect. First of all, you have to have a high clinical index of suspicion to do them. Because if you start doing them in everybody who, for example, has gained some weight, or everybody who's got type 2 diabetes, you throw out what's called a false positive when the test is positive, but the patient doesn't have the disease. So it's very, very important that first of all, you assess the patient clinically, you take a history, careful examination, and you think what your clinical index of suspicion is for Cushing's before you embark on the test. And the other thing that sometimes happens, which I know probably can be a bit frustrating for patients, is that often I find that time is helpful. Obviously, if someone's very poorly, you would be moving very quickly and time wouldn't be an issue. But sometimes when it's not really very clear clinically, and actually I'm not really sure diagnostically where we are, actually a good thing to do is pause and reassess and repeat tests over a period of time, because you're waiting to see and giving yourself more evidence, because the last thing you want to do is label someone with this and ask them to have an unnecessary operation. Obviously for Cushing's disease, where that's a pituitary tumour making too much ACTH, it's going to be an unnecessary pituitary operation if that's not the correct diagnosis. And then also to make our life more challenging, sometimes with Cushing's disease, although there is a pituitary tumour making too much ACTH, the MRI can be normal, so you can't always see the tumour on the pituitary MRI. And then the other thing that's tricky is that some other medical conditions can cause our test for Cushing's to be positive even when the diagnosis isn't Cushing's. So a good example of that is obstructive sleep apnea. But just explain that for a minute. Obstructive sleep apnea is when you might be totally unaware that you're someone who snores quite a lot. And when we snore, if it's a particular issue, what can happen is we don't go into deep sleep properly. And deep sleep is where we get our most refreshing sleep. And what happens in these patients with obstructive sleep apnea is that they end up sort of block. I'm not a respiratory physician, so I'm going to describe this very inelegantly, but they block off their windpipe a little as they fall deeply asleep. They sort of wake up. They might not even be fully awake and know that they've woken up, but they're stopping themselves all the time from going into a deep, refreshing sleep. So they end up being very, very tired in the daytime because they've actually not slept well at all. They've not had a deep, refreshing sleep. And the issue for this condition, obstructive sleep apnea, is it's not uncommon. It can be associated with an increase in weight gain. And the difficulty is because it's quite stressful for the body to be sort of constantly waking up like that, it can then cause a false positive on our Cushing's test. So the body can make a little bit too much cortisol because actually it's a bit stressed that you're not getting a good night's sleep. And so it can cause us to have some difficulty about interpreting the test for Cushing's. Again, that might be why we treat someone's obstructive sleep apnea and then repeat the test down the line. So this is showing you and reminding you, for those of you who've had Cushing's, that typically the first line treatment for Cushing's, unless there were a problem where a patient couldn't have an operation, is transphenoidal pituitary surgery. The surgeon will go up the nose here, as you can see. This is then still within our noses are this is the sinus. These folds are called the turbinates. They go up here, they drill this wall here and get into this space, which is called the sphenoid sinus, as you can see here. They push through the sphenoid sinus, which is air-filled, and then here is our pituitary gland. It's sitting in this little bony dish, and the surgeon burrows it in with their drill and pulls out the pituitary tumour through the nose. Obviously, a lot of skill involved, but that's what it involves. And the aim, of course, is to take out this pituitary tumour making too much ACTH in Cushing's. Now, sometimes we do like to give medications to patients with Cushing's disease before their surgery to lower the cortisol. And that really depends on lots of things, how quickly we can get the surgery done, and how unwell the patient is. If the patient's very poorly, and you can be very poorly with Cushing's disease, we may well lower the cortisol to try and make the patient feel a bit better and for us to be feeling better about their general health, such as their diabetes, for example, their blood pressure, before we ask them to have their surgery. Sometimes surgery isn't possible. Maybe someone's very unwell or too frail to have a general anaesthetic, or sometimes it's been difficult to take all the tumour away with the transsphenoidal surgery up the nose. And if that's the case, we would either refer for something called radiotherapy, and you can see this patient here who's beneath the radiotherapy mask, keeping her head very still while she has her radiotherapy. Radiotherapy is like deep X-ray treatment. It is very slow to work. So usually, if you are having radiotherapy for Cushing's, you might end up having medical treatment at least for a few years whilst the radiotherapy takes effect. And sometimes patients might need medical treatment after surgery. Again, if all the tumour hasn't been taken away, it might be a decision not to use radiotherapy, but just to manage with medication. Okay, so what sort of medications can we use in Cushing's disease? As we've talked about, Cushing's disease is a pituitary tumour here, making too much ACTH, telling the adrenal glands, the cortex, to make too much cortisol. Some of you may recognise this name. It's a drug called metyrapone. This switches off cortisol production from the adrenal gland and lowers cortisol. There's a new drug available, which I mentioned in the Cushing's blog, actually, that I've done with the Pituitary Foundation. This is not available across the UK. It's very new, but it's becoming more and more widely used, let's just say, called osilodrostat, which similarly reduces cortisol production. And then there is also a drug called pasireotide, which can try and switch off ACTH production from the pituitary. I thought I'd just mention for a minute about blood thinners in Cushing's management. So blood thinners are increasingly used in patients with Cushing's disease. I certainly use them all the time now for patients with Cushing's disease, and I probably didn't 5 years ago, let's just say. So we know that Cushing's disease or Cushing's syndrome increases the risk of blood clots. So the high levels of cortisol tend to make the blood more gloopy, let's just say. And those clots can form in the legs, in the veins in the legs, and they can travel elsewhere to the lungs. And we call that thromboembolism. So thrombus is the clot, and embolism is where it moves and lodges somewhere else. And that's obviously not good for you. So the last thing we want is someone who's got a tendency towards a clot, particularly when our first line of treating patients is going to be a surgery, which again will increase the risk of clot. So most centres, or many centres anyway, will be providing patients with blood thinners once a diagnosis of Cushing's disease is made. We might stop it transiently depending on certain procedures such as inferior petrosal sinus sampling, and we stop it around the time of pituitary surgery, and then typically we continue this for a few months after surgery. I'm conscious that not every centre is doing this, but I think this is probably the direction of travel for lots of centres, and I thought it would just be worth talking about it for a minute. Now, just the other important thing to say is that typically after surgery for Cushing's disease, you can feel really dreadful, and that's a shame because, you know, you've probably had lots of time going into the surgery thinking, gosh, if I can just get this done, I'm going to feel better. But the problem is in Cushing's disease, even if you've had medication to lower your cortisol before your surgery, you have had very high ACTH and hence cortisol levels for a period of time, and your body has been used to those very high levels of cortisol. And so as the tumour's taken away, you get less ACTH production, less cortisol, your cortisol levels fall. You might actually feel a bit dreadful because you're not used to lower cortisol levels like this. Typically, and certainly what we would do, is in a patient who's had Cushing's disease, after their surgery, we give them quite a generous dose of cortisol replacement, either hydrocortisone or prednisolone, because what we're wanting to do is not make them feel too dreadful by bringing that cortisol down too quickly. So we give them a generous dose, and then over time, we will inch down slowly on that dose. So in a perfect situation, what will happen is after your surgery, and it's a very sort of non-specified time, as the cortisol falls because your tumour making too much ACTH has been taken out, what happens is the normal ACTH producing cells in your pituitary slowly begin to wake up because the cortisol has fallen. And as they wake up and do their normal thing, you may be able to ultimately discontinue your steroid. And that is what the sort of ultimate aim is. However, as you all know, all of you who are taking steroids, tablets, either hydrocortisone or prednisolone, that's a very, very important tablet for your well-being. So you would only do this very, very carefully in a controlled way with your medical team. And that's really very specifically in the context of Cushing's disease. Not everybody is able to stop their steroids after surgery for Cushing's disease. Very much depends on an individual patient basis. So just to summarise, and I think I'm just at 30 minutes, so hopefully that's okay timing wise. So just to remind ourselves, Cushing's disease is rare but important to diagnose. Sometimes the diagnosis can be slow, and that doesn't mean that your doctors and your clinical teams don't know what they're doing. It really does require multiple tests and a really careful approach. And that's because you really need to get the correct diagnosis to get the right treatment. So sometimes it might seem that, you know, why people repeating things, it's because they want to be very, very clear about the diagnosis. And as I've mentioned, we all know in the endocrine community that sometimes it can be quite a tricky diagnosis. You want to be confident you've made the right diagnosis. If you have a diagnosis of Cushing's disease where you have an ACTH secreting or producing tumour of the pituitary, your first option, unless you're not well enough for surgery, will be pituitary surgery. It's called transsphenoidal when you go up the nose. And there are medications which we use to reduce the cortisol before surgery in some circumstances, depending on the wait for surgery and how unwell you are before surgery. But we might also use those medications whilst we're waiting for radiotherapy to work. And as I've mentioned, some of those medications, or certainly sort of newer things that we're doing around managing Cushing's with medication, are in the blog that Amy and I organised. So I'm going to end it there, and thank you for listening. I'm going to stop sharing in a second.